Hello, welcome to another session of our digital surgical slide review and sign out. I'm Dr. Lewis Hassel, our program part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. Our case today comes from the realm of GYN pathology. It's an 80-year-old woman who has a history of both upper and lower tract urothelial cell carcinoma. These were several years ago, and she now has an asymptomatic adnexal mass, unilateral. So this case presents a rationale for digitization of surgical pathology. And I'll just mention this, that one of the most important resources available to a pathologist is the archive of prior pathologic materials. In this case, they were not immediately available. Being able to retrieve prior slides is valuable, particularly when you have an intraoperative issue that arises and the slide files are deep in the archives of the hospital, perhaps even off-site. And so maintaining a digital archive of slides offers the best way to ensure this. This is perhaps the most cost-effective special stain. So there's my little pitch, and now we'll tell you the story. The adnexal mass came from frozen section. And here's the frozen section slide. And as you can see, this is a neoplasm. We've got cellular areas here. We've got some reactive stroma. We've got some open spaces, maybe glandular forming spaces. And we also have a lot of sort of clear-ish type of cytoplasm. At the time of intraoperative consultation, we thought this could be a variety of things. The possibility of clear cell carcinoma was included in our differential, sort of a solid variant. The history of upper and lower urinary tract disease was not, was not widely disclosed on the surgical historical form, and so other lesions, other metastatic or primary lesions, Brenner tumor, malignant Brenner tumor, or something of that sort, were also considered for this lesion. And that presented a little bit of a problem because this was called a carcinoma, high grade, not otherwise specified. The surgeon was a bit at a loss as to whether to stage this as a primary ovarian lesion, which is what she ended up doing, or whether they should assume this is a metastasis and finish the case. So having made that part of the story, let's look at the permanent sections. And as you can see, it looks similar to what we had on frozen section. Sort of a maturing solid tumor with prominent cell borders and fairly uniform nuclei. The appearance here prompted, again, retrieval of the prior slides, which on retrieval look remarkably similar to what we have here, as well as the performance of some additional immunohistochemical stains. So in this case, the tumor cells were positive for GATA3. They were positive for P63, CK20, while they were negative for PAX8 and WT1. Now, primary urothelial tumors of the ovary, primary transitional carcinoma of the ovary, typically is positive for PAX8 and WT1, while being negative for GATA3, P63, and CK20. So our findings with this panel were very helpful. In contrast, doing P53 stains, CK7 stains, ERPR And some of the more commonly touted urothelial markers like uroplakin and thrombomodulin, these are not particularly discriminant between a primary versus a metastatic lesion arising in the ovary. So these ovarian primary tumors that are primary transitional cell carcinomas are really derived from the common epithelium. They're not a true urothelial type lesion. So our final sign out diagnosis is metastatic carcinoma from the urothelial primary involving the ovary. We hope you enjoyed that case, and if you liked it, please subscribe, share with your colleagues and friends, and send us a comment when you have a chance.